Good morning. Today we will be discussing on complications of peptic ulcer. The most common complications we come across in peptic ulcer is number 1, perforation of peptic ulcer. Number 2 is stenosis, that is also called pyloric stenosis or gastric outlet obstruction. And number 3 is hemorrhage, bleeding, which results in hematomasis and melena. To start with, perforation of peptic ulcer. The incidence of perforation of peptic ulcer has decreased with the upcoming and judicious use of PPI. But still, we quite frequently get patients of duodenal ulcer perforation in our emergency unit care. These are those patients especially who are neglected, they have not got themselves treated properly, or they have a history of irregular intake of drugs by the drugstore people, or they have a precipitating factor like NSAID intake or other things apart from being treated with for peptic ulcer. So, to say that incidence has decreased, but it is still available. The patient of a duodenal perforation comes to you with severe pain abdomen. The pain is all over the abdomen, especially in the epigastric and the right iliac fossa. This is due to gushing of the gastric fluid in the peritoneal cavity. The fluid has a low viral load, low bacterial load, and at the same time the fluid spreads in the peritoneal cavity and results in pain. If it is left over, sequelae changes, the bacterial growth takes place, and a frank bacterial peritonitis develops to the patient. When a bacterial peritonitis develops to a patient of a perforation, the clinical features also change. The patient becomes in the state of shock, that is, there is tachycardia, there is hyperapnea, as well as the patient has fever and other features of shock. But to diagnose such patients of duodenal ulcer perforation, it is very simple. What we actually require is a plain X-ray abdomen in erect posture. The purpose of putting the patient in an erect posture is that when the perforation has occurred, the air in the peritoneal cavity comes up when you are standing. So you get gas in the radiological view, gas under right dome of diaphragm. That is diagnostic for perforation more or less if the patient has no other history of laparotomy or laparoscopy. There are other conditions also where you get gas and the right dome of diaphragm. The second condition, the second investigation we do is serum amylase. Serum amylase is raised in duodenal ulcer perforation also and is raised tremendously in acute peritonitis. The clinical features of acute peritonitis and duodenal ulcer perforation is more or less very similar initially. But serum amylase is slightly raised in duodenal ulcer perforation, but is very high in case of acute peritonitis. So you can exclude acute peritonitis with this investigation. There is another investigation which used to be done earlier, but nowadays it's not been done. Is that when you have doubt, you can still do it, is that you make the patient swallow a soluble contrast and then take an X-ray. The contrast spreads into the peritoneal cavity through the perforation. So these are the investigations we have to do in perforation of duodenal ulcer. The clinical features are very clear, very simple to diagnose, and the answer is surgery, no other treatment. Firstly, you build up the patient, and then go for surgery. The earlier you go for surgery, the better is the prognosis. If the bacterial peritonitis and a state of shock has come up, results are equivocal. Otherwise, the results are very encouraging if you operate the patient very early. What operation we do? We open the abdomen by midline. We isolate the first part of duodenum, and we ease the perforation as you have already been taught. The anterior part is perforated and the posterior bleeds. The anterior perforation is seen very clearly on the operation table. It is closed by interrupted sutures. The closure can be done over a mental patch, or the closure can be done a simple closure. It depends upon the surgeon how they close this. But both results are good, and both the process is acceptable in the text. So the closure is done initially, and then a thorough peritoneal lavage is done. This helps in decreasing the toxemia of the patient, because all the infected fluid is in the abdomen, and a lavage helps the patient cope up with the toxemia. This is how we treat a patient of perforated duodenal ulcer. Thank you. Second is a gastric outlet obstruction. Now, the most common cause of gastric outlet obstruction, if the patient presents to you, is gastric cancer. For all practical purposes, it's gastric cancer. Until other proof otherwise, the duodenal ulcer may be a cause of gastric outlet obstruction. Usually, in a gastric ulcer, it results in the pyloric stenosis, and in a duodenal ulcer, the stenosis in the first part of duodenum, the results are the same. Presentations are the same in both cases. So, what we do actually in a gastric, how the patient presents with a gastric outlet obstruction. The main feature is vomiting, a persistent vomiting. There are two important things in the vomiting of this patients. Number one is when the patient vomits, it contains no bile. This is very important. Number two is when the patient vomits, the contents are what the patient has taken 2-3 days previously. It improved 2-3 days previously, the contents come out. So this is typical. The patient will himself tell you, 2-3 दिन पहले खाया था वो अब निकल रहा है. So this is the typical presentation of pyloric stenosis or a gastric outlet obstruction. Now, this persistent vomiting leads to severe metabolic disturbances. And ultimately what happens to the patient? It comes with alkalosis and hypokalemia. So when it comes to you, the patient is grossly dehydrated, it's hypokalemic and metabolic alkalosis which is there, and then you examine the patient. What first thing you do is put a wide bore nasal cannula inside and take a good picture and wash the stomach very clearly, very nicely, so that diagnosis of the disease can be done. The diagnosis is done by endoscopy is the best. You put in the endoscope. If it is a gastric ulcer, you come across a dry ulcer in the pylorus near the pre-pyloric area, you go for at least 10 biopsies from the ulcer and diagnose it and send it for histopathological examination. If it is duodenal ulcer, the first part of duodenum is actually involved where the obstruction has taken place. So there you just see the patient, and if it is an early case and patient may be moribund, may be not fit for surgery, so in such cases you try for a balloon dilatation. What is the balloon dilatation? Through the endoscope, we put in a wire and negotiate the stenosis side. If it is able to negotiate, that's very difficult, but still if you negotiate it and dilate the balloon, the opening, stenosis opens and the patient can eat properly. So these is not done normally, but it is done with a patient who is not fit for surgery, usually, and secondly in the early case. Now, if the patient is diagnosed as a malignant, the treatment will be as gastric cancer, which we will discuss later on. If the patient is not a gastric cancer, then we go for a surgery. The surgery is the best treatment. What surgery we do? We go for a gastroenterostomy. Enterostomy, matlab gastric, and the gut is anastomosis. The bypass is done and the food now from the stomach goes directly to the gut, small gut. So what enterostomy is done? It's gastrojejunostomy. So that is what exactly is done to bypass the food particle inside the jejunum. So the pyloric stenosis is left as such. The food is bypassed. So symptoms evade and the patient copes up normally. We can also go for a pyloroplasty. A pyloroplasty is that you put a transverse incision over the pylorus 1 cm proximal, 1 cm distal and close it vertically. So then that pyloroplasty is not used nowadays. Gastroenterostomy is the choice of operation that is done. Thank you very much. We will discuss about the bleeding part in the next chapter, next class, which is very long, and we will discuss in detail. Thank you very much. Sanjay ji, Upendra, हो गया संजय बोलो. संजय 15 मिनट का क्लास है. प्रति जगह हो गया. देख लीजिए एक बार करीब जाने के पहले देख लें.